So bone quality declines during menopause for women. This is predictable and ultimately preventable. Yet, for the past 20 years, women have been denied an accurate discussion of the risks and benefits of hormone replacement therapy as it relates to bone health. Why? Well, it all comes down to the Women's Health Initiative and other studies that came out at the same time and the impact that those had on clinical treatment for hormones. This is especially true for women who were at the time, or over the subsequent 20 years, over 10 years out from menopause, who then had a desire to consider hormone replacement therapy. Now, I view things very differently than most doctors do currently, but especially then, because we see that women over 10 years out from menopause or over the age of 60, depending on the study, we see HRT as a tool for these patients because the benefits so clearly outweigh the risks. And there's a recent article that really supports this idea. This was published in The Lancet just this last month in January 2025. So it actually stimulated me to make this video. Now, as usual, and this annoys me, and I get it, journals have to make money, but as usual, this journal article is behind a paywall, so you'd have to pay $35 to read it, and most people aren't going to do that. But I want to bring it here because they make some great points that are in addition to the things that I usually say with this age group around hormones. So stick around because I'm going to talk about the tools that I think you're going to need to have a conversation with your healthcare provider around considering HRT, especially being over 10 years out from menopause, if you want to optimize your bone, your heart, your brain, your sexual health, and more. This is a very challenging conversation, and many physicians have really deep-seated beliefs around the use of hormones for these things. But the more you know, the better you can prepare yourself to have these conversations. All right, so this is the story I hear all the time, even in my own mother. For women who are over the age of 60, they generally, the vast majority of them, in my experience, were never offered HRT. Because of the timing in which they went through menopause, it wasn't really considered to be an option for them, although it certainly should have. They likely suffered through the vasomotor symptoms, the genitourinary symptoms of menopause, and have come out on the other side of this, hopefully not still experiencing those things, but oftentimes they even are. Now they also find out that they have osteoporosis. Sometimes they're going to do the research and they're going to find the tools. They're going to say, oh my gosh, I would love to consider hormone replacement therapy. And they ask their doctor and their doctor says, no, it's too late. It's too dangerous. Does that sound familiar? It should, because an entire generation of women have been denied care and are now facing declining bone health as a result of not having optimized hormones. They're looking for tools to improve their bones, and rightfully so, they find HRT, but now they're told that it's too late. If this is you and you're angry, you should be. But before you switch videos to consider something that you think might be safe for you, hear me out. Women over the age of 60 in our practice are starting HRT comfortably, calmly, because they're armed with the right knowledge and testing to feel secure in their decision about using HRT to protect their bones, probably their heart, probably their brain, probably their sexual health, and more. So then how is it that we're able to do this in our practice when most patients are going to their doctors and their doctors are saying, no, it's too dangerous? Let me explain the discrepancy here. See, it all starts again with the Women's Health Initiative and other studies that came out at a similar time. Now, if you're not familiar with this study, I'll describe it briefly. But basically, the Women's Health Initiative is the study that had the biggest impact on hormone care in the early 2000s. It was a study that started in the 90s and had two different groups of women who were on hormone replacement therapy of some kind compared to placebo. And the outcomes of these studies changed the way that we prescribe hormones probably forever. But definitely in the near term, millions and millions of women were taken off of their HRT because of the quote-unquote risk associated with HRT. So let me explain, I'm not going to go through all the details here, but let me just explain what happened for women over the age of 60 or over 10 years out from menopause. So if you look at this table from this follow-up study, which actually just came out last year in 2024. So there's a couple of different ways to look at this. You can look at the data from the 2002 and 2004 publications that showed the increased risk of heart attack, heart disease, stroke, potentially breast cancer. There is a trend toward increased risk in all these things, particularly in the combined trial. Now, combined, meaning that they were both on some form of estrogen and some form of progestogen. There was also an estrogen-only group. But let me just take a quick moment to just say the estrogen that they were on was conjugated equine estrogen, known at that time as Prevaren, is the brand name of CED, conjugated equine estrogen. This is a synthetic estrogen that doesn't have much market share anymore, and certainly I wouldn't recommend using it. It's also oral, which has implications as well. Then they were on medroxyprogesterone acetate, MPA. This is a synthetic progestogen, a progestin, that also, now we know over the last 20 years of being studied, has other potential negatives. It could be responsible for some of the findings of these studies. So you're on what I would consider crappy HRT, and I'm just going to keep calling it that. It's crappy HRT. They're on crappy HRT, and they found some risk. The estrogen or Prevaren only group also found some risk, but not of the breast cancer side, but still in the stroke and heart disease side. So it's something to have a discussion about. But we also now have follow-up data. So there's 2 follow-up studies over the course of the last 20 years. And then finally, last year, they published this, I don't know if it's final, but a long-term follow-up study showing whether or not the risk that occurred during the intervention phases in the early 2000s, whether that risk persisted over time, because they followed these women over time. So now we have a lot of data to actually compare what's happening when it comes to risk in the decision-making around hormones. Now, what we saw in the early data, in the intervention data, is that if you were to extrapolate by age, if you start hormone replacement therapy, even crappy therapy, within the first 10 years after menopause, you are protected specifically from heart disease. This is a big deal. This is why we should be having this conversation with every woman who goes through menopause, talking about the potential benefits that are known. Most women don't have that conversation. But here's what happens. Most women also were not offered HRT during that time. They didn't have that conversation, and now they're over 10 years out from menopause. Now, what this table clearly shows is that, yes, if you start hormones within the first 10 years after menopause, you are protected from heart disease, according to this table. But if you look at the group that's 60 to 69 years old, women that are over 10 years out from menopause, if you look at these numbers, they're still protected from heart disease. It's just not statistically significant, so we can't say that it's not better than placebo. But what we can say is that it's not worse either. So yes, it would have been safer to start it within 10 years of menopause, but I don't have the time clock that can take us back in time and time travel to start this 10 years early. We don't have that tool. All we have is what we have right now in this present moment. So in the moment, is it riskier than placebo to start HRT for women in this group, age 60 to 69? So yes, it's safer to start 10 years earlier, but I don't have the ability to time travel. I can't take you back 10 years ago and start earlier. We only have the present moment. I only have now. So now, is starting HRT in this group riskier than placebo? And the answer is no. So if it's not riskier than placebo, why are we denying this for women over the age of 60 or 10 years out from menopause? I don't get it. Somebody explain it to me. I think that it just has to do with this fear, this misunderstanding of the data to say, oh, it's too risky because it's not protective of heart disease anymore. But the risk-benefit equation needs to include all things. What's happening from a sexual health perspective, from a GSM perspective, what's happening with your bones. If you're having issues with those things that we know are clearly going to be benefited from HRT, and there's no increased risk of having a heart attack, heart disease, or anything like that, blood clot, PE, whatever, there's no increased risk compared to placebo, then what are we worried about? Really, really frustrating for me. Now, if you go another 10 years, and now patients are over 20 years out from menopause or over the age of 70, you do start to see that risk go up. Why? That's because we know that estrogen is protective of heart disease. So if you've been 20 years without estrogen exposure, that's a long time. Your arteries are going to look different. Depending on other risk factors, you may be developing plaque, you may have significant heart disease, and then starting estrogen may actually be more dangerous than not. But this really has to come down to individuality and individual risk factors, because in our patients, I don't see women who have a lot of cardiovascular risk over the age of 70 with osteoporosis. Of course it exists, but generally my patients are healthier. They have good looking arteries, and I'll explain how we do that, but it is not unreasonable to start HRT even over 20 years out from menopause. Now, how is it that people misunderstood this? And how is it even that that risk showed up a little bit in the first place? Well, we have to understand that the Women's Health Initiative had a lot of potential negatives in the way that it was designed. One of those negatives is that the study group was older, because they were looking for people that didn't have symptoms of menopause. So they were older than most women are as they go through menopause. There's a higher percentage of obesity, about a third of the intervention group, hypertension or treated hypertension, and about a third. And 10% of them were smokers. That's a lot of risk factors and known risk factors for hormone replacement therapy. So if you had that group and they were on crappy HRT, do these risk factors even apply to my population? We need to consider it, but my patients are not that population. Before I tell you how we risk stratify, because again, my patients don't seem to be that same population, I'm also going to talk about this new article that was published just last month. But if you are struggling to put together your own bone health program and you have some questions, please consider coming to our free masterclass. We talk about the common myths and misconceptions that we see in our community and our patients, and I answer questions for about 20 minutes at the end. It's a really valuable tool that hundreds of people are doing every other week. So if you haven't done it, please do it. This is something that I'm doing for you. I would encourage you to check it out. The link is in the description on YouTube. All right, so this study that was published last month is an in-depth review of the literature over the last 25 years. And I think they do a really good job of pointing out the shifts in care that occurred, obviously as a result of the WHI, but also the discrepancies in the care that has gotten bigger and bigger because the care that women are receiving is not the same, it is not supported by the current literature. Now, they start off by talking about these consensus statements that started in the early 2000s as a result of the WHI. One of the things I want to point out here is that these consensus statements just simply recommend that doctors look at the risk-benefit equation. And they say this. They say the risks only outweigh the benefits for symptomatic, otherwise healthy women within 10 years of menopause. What does that mean? Symptomatic means vasomotor for the most part. Most doctors aren't actually asking about genitourinary symptoms. So generally, we're talking vasomotor symptoms for otherwise healthy women within 10 years. I think that's an interesting statement because sometimes the otherwise unhealthy part, like osteoporosis, would have a significant influence here. Anyway, they go on to say that outside of that, individual risk factors need to be considered. What they're saying with that is, if you're over 10 years out from menopause or you're not an otherwise healthy woman, you need to individually consider risk factors. But that's it. They never said don't use it for women who are over 10 years out from menopause. That was never the recommendation. But doctors took that as to say the only women who should be offered HRT, if any, are healthy women within 10 years of menopause. And that's what's happened over the last 20 plus years. So this article goes on to discuss three main topics: cardiovascular risk, which is the biggest part, dementia risk, which is really interesting, and then they touch on fracture risk a little bit. Now, the thing that they didn't talk about that you might be wondering is cancer risk. I hear this all the time. Oh, my doctor doesn't want me to start HRT. I'm over 60 because it increases my risk of cancer. That is absolutely not true. The cancer risk associated with hormone replacement therapy, if it exists at all, which is a whole nother video, but if that cancer risk is present, it is not age dependent. Meaning that there's no difference in cancer risk if you start after the age of 60 or 70 or even 80 or 90. It more has to do with heart disease than anything else, and there's a discussion around dementia here as well. So let's break this down. Now, this article is actually kind of hard to read because they talk about all the specific things that are broken down. So you're talking about VTE, which is venous thromboembolism. You're talking about CHD, coronary heart disease, MI, myocardial infarction, heart attack. So it's pretty technical and it can be hard to read, but let me break down some of these things because it makes some very clear points that would be easy to miss if they weren't explained in a different way. So when it comes down to coronary heart disease, this is actually the development of plaque within the arteries that give blood to the heart. There is an increased risk for women age 70 to 79 or over 20 years out from menopause in the intervention phase of the Women's Health Initiative. But if you look at the follow-up studies, that risk does not persist. What does that mean? It means that it occurred early on, but if you follow these patients over time, it's not different than placebo. And arguably at the time, it wasn't statistically significant anyway. So now if I were to use all of this data to educate my patients, I would say that there is no increased risk for women 70 to 79. That doesn't mean I'm going to prescribe for all those women. It just means that as a group, we don't need to consider them actually at higher risk. Now, for heart attack specifically, there was a marginally higher risk in women who are over 20 years out from menopause. But remember that that group also had additional risk factors: smokers, obesity, hypertension, and they were on crappy HRT. It's going to keep calling it that. The stroke risk that was present in the initial studies also went away with long-term follow-up. So again, if you follow people long enough, if the groups aren't actually different, it's going to level out over time. This is why long studies are important. Now, what's interesting is that PE, or pulmonary embolism, was actually higher in the combined group, even in older women, even in younger women, actually. But this is one of the reasons why we don't use medroxyprogesterone acetate. And if you look at the CE only group, the estrogen only group, there was not an increased risk of stroke over time. So I think we can actually blame probably the NPA, the progestin, for this increased risk initially seen and persisted over time. Now, if you look at all these risks together, they end up coming in somewhere around between 8 and 26 additional events per 10,000 women per year. Now, that risk of side effect is rare by definition. Now, this is really important because rare side effects happen with drugs and other treatments and surgeries all the time. And we don't not offer them as a result of rare side effects. It's good to discuss them for informed consent, but we don't necessarily not offer them. Consider oral contraceptives. So birth control pills have a known increased risk of blood clot, for example, and other things. Some studies show up to 6x increase in blood clot with synthetic estrogen and progestin oral contraceptives pill. Does that stop us from prescribing it to millions of women? No. It's one of the most commonly prescribed drugs out there. We know that it has this increased risk, and women should be told about it. They probably aren't. They should be told about it. But even then, they're going to decide to use it because of the risk-benefit equation. We don't prevent women from being prescribed it. We just try to educate them about the potential risks. Now, I personally wouldn't use them, but lots of doctors are. And to have a difference in the way that we would recommend or not recommend HRT because of a known rare risk, 6x is not rare, but a known rare risk, I think is just not fair. We're not offering to an older population of women the same potential benefits as we are to a younger population, but something that's actually less risky, if that makes sense. Now, you can also look at this from a testosterone perspective. So I recently listened to an interview with Dr. Kelly Casperson. So she's a urologist. So she deals with hormones on both sexes. And she compared the recommendations actually out of this Lancet article to the Traverse study. So the Traverse study is a study on testosterone and men that are high risk of heart attack, because there's some concern that testosterone replacement can cause an increased risk of heart attack. And what was cool about this study, even though I wish it were done differently, but what's cool about this study is that it did not show an increased risk of heart attack. Great. But it did show an increased risk of pulmonary embolism, acute kidney injury, and AFib. What were the recommendations from the authors, and did the consensus statements actually change as a result of this? So actually, they didn't really say much about it. They reported it, but then it didn't really talk about it. The consensus statements didn't change, and I don't really think prescribing patterns changed. I'm not sure if those risks are real. Was that by chance? That's a whole different conversation, but ultimately they are rare, and they're an accepted risk of using exogenous testosterone. Does the benefit outweigh the risk? And for most men, the answer was yes, and I agree. So I treat men the same way. I use testosterone, and I recognize that this potential risk is there, but it's extremely rare, and not all studies support that. So what can we say? Rare events are going to occur. We want to mention them. We want to talk about them. But just like other drugs, we should just add them into the risk-benefit equation. We have to also then stratify other diseases into that equation, like, say, osteoporosis. So if someone has osteoporosis, are we more worried about their hip fracture, their loss of independence, their pain, their change in spinal alignment as a result of fracture? Is that a bigger risk? Or is it this rare, subtle, increased risk of pulmonary embolism and stroke, which, again, was only due to crappy hormones in the first place? How's that going to balance out in your head? I know what my answer is. But let's talk about dementia. So dementia is interesting because, first of all, cognitive decline is hard to measure. So there are not great tools to measure cognitive function in high-functioning individuals. Mild cognitive impairment is actually hard to catch early on. There really aren't great instruments. So out of the gate, when you're looking at, is hormone replacement going to have a negative impact on cognitive function? This is a hard study to do. Now, the Women's Health Initiative tried to do it. So the Women's Health Initiative memory study, WHIMS, tried to find whether or not there was an increased or decreased risk of dementia associated with HRT use. What they found, though, and reported, is that there is a 2 times increase in probable dementia in women over the age of 65 that were assigned to the HRT group. Now, that risk comes out to, again, around 23 per 10,000 women per year. So again, this is rare. But what's interesting here is that if you look at the estrogen-only group, there was no increased risk. So same thing, was it the progestin or was it really relevant at all? So to understand that, we need to look a little bit deeper. There's some follow-up studies on this with this WIM study, and what they found is that if you follow these women over time, you would expect if they were developing dementia at a higher rate that they would die from dementia at a higher rate, and they did not. In fact, the estrogen-only group was actually protected from a diagnosis of Alzheimer's and other dementias. So it kind of sounds like the same argument around breast cancer, where it looked like maybe there was an increased risk, but it doesn't play out over time. And in the estrogen group, they were protected of it. Now, also in the combined group, what's interesting, if you look at the study details, is that only 40% of the participants actually filled out the follow-up data. So it clearly is going to represent a significant amount of bias. When you have less than a 50% follow-up, it's really hard to draw conclusions from that. In addition, the instrument that they use to measure this, I mentioned we don't have great tools. So they used one I'd never heard of. It's called the California Verbal Learning Test Score. And of that test, only one subdomain actually showed a reduction in performance. But the question is that even clinically relevant? Like, what does that even mean? What is that test actually used for? And what is it actually sensitive to? Maybe it's relevant, but should we not offer HRT because of this one thing? I think clearly not. Maybe we need to know more information, but it's not going to stop me from prescribing. Additionally, my clinical experience says cognitive improvement is profound with HRT for some women, maybe not all, but I find that women are thinking better, they have less brain fog, they have better energy, better vitality. Their brain just seems to work better. And it makes sense because we have estrogen and progesterone receptors on our nervous system. So it's likely going to have a big impact. So I don't think that this study is a reason not to prescribe it. Now, could I say you should use HRT to prevent dementia? I don't think we can really say that either. I think it's probably true, but I don't think we have a good enough study to show that. But I'm here more for health optimization. And if a woman's going to use HRT for a specific reason, but also potentially get the benefits that are a little less known, like is it going to benefit a woman over the age of 60 with heart disease? Is it going to help to prevent dementia? I can't clearly say that those things are true. I think they're likely true, and we've already decided based off of other factors, the risk to benefit equation around using HRT, so why not? So then finally they get to bone health, and I kind of like what they say, which is like nobody's arguing whether or not hormones are good for bone health, they're just not using it. People aren't also saying how profound it can be for bone health. And again, I have studies that I talk about that show up to 10% improvement in bone mineral density in the course of 12 months. Massive, right? It's better than really any drug because you can use it long term. So what do we do? Well, ultimately we have the conversation. I would never want to deny care without the conversation about risk benefit from the perspective of understanding both the risk and the benefit. And if your doctor is doing that, I hate saying this, but you might need to find a second opinion or a new doctor because they're just not open to having this conversation with you and helping you to go down the path that you think that you need to be on. You have to advocate for yourself. Remember, even in the early guidelines, no one said don't use it for women over the age of 60 or 10 years off from menopause. They just said consider the individual risk factors. Also remember that in the WHI, a third obese, a third hypertension, 10% smokers. What would those data points look like if they didn't have those pre-existing risk factors? What if they were using different forms of hormone replacement therapy? What if they were using bioidentical estradiol cream, micronized progesterone capsules, and plus or minus testosterone? Lastly, if you have osteoporosis, your risk equation is different than if you don't. What is the risk of fracture? What is the risk of loss of independence or even death as a result of a hip fracture, loss of function from a spine fracture, the pain, the treatment, etc. You have to look at this through that lens. If you have poor bone health and you're trying to improve your bone health, HRT can be profoundly impactful, but it has to be done right, and individual risk factors really do need to be considered. I do not treat all patients with osteoporosis with hormones because some people do have risk factors. The risk factors we look at are chronic inflammation, metabolic dysfunction, insulin resistance, hypertension, genetics, family history, modifiable risk factors like smoking, vaping, other bad lifestyle choices. We can also look at advanced markers like ApoB, Lp(a), Lp(PLA2), CRP, and more to identify what's happening in the blood to help identify risk. We can also image the arteries. There's so much we can do to help identify what kind of risk we have for our patients that are over the age of 60 or over the age of 70. So, do the risk factors for my patients match those of the studies that were used to make these recommendations in the first place? No. We have patients that are over the age of 70 who they've gone through the testing, they've looked at the blood, we've looked at the imaging, and their arteries look better than mine. So if coronary heart disease is all I'm worried about when it comes to starting HRT, it's not, but if that's the primary thing, why would I prevent them from going on it if that's their goal and desire? Why would I prevent them from going on it? I think that HRT should be considered for all women, almost regardless of age. If a woman is within 10 years of menopause, there's no question, unless there's a clear contraindications, that she would benefit from HRT. For a woman 10 to 20 years out, I rarely have an objection, but we might want to do a little more research. For women over 20 years out, it gets a little bit tougher, but I still think that it is an option for some women. It's just a smaller group. And remember that a diagnosis of osteoporosis actually changes the equation. There's much more risk with those pre-existing factors, those pre-existing diagnoses. Then understand that these risks from the Women's Health Initiative are rare, and that in men or in younger women, they would be ignored. And that's a good frame to consider for older women as well. So that's it. That's my rant on when to start HRT. Remember that a diagnosis of osteoporosis isn't the end, but deciding to reverse it is the beginning. I'll see you in the next video.